Building your workforce pipeline as a nurse executive is our episode topic. Rejoining us as guest is Susan Stacey, a registered nurse and the chief executive for Providence Health's Inland Northwest Service Area. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Susan, welcome back. Thank you so much for joining us again today.
Thank you. Happy to be here.
Our topic today is building your workforce pipeline as a nurse executive. Tell me, what's your approach to looking at workforce development at Providence Inland Northwest area?
Historically, we've looked at workforce development as a recruiting and hiring issue, and it was the school's problem and everyone else's to produce healthcare workers. That world changed for me really actually right before the pandemic, when we started seeing early shortages in some of these entry-level staff roles. And I realized that we could not rely on the schools to do it all. Faculty positions were starting to decrease. We were seeing decreased enrollments in school. And you also couldn't think just about doctors and nurses. We have a little bit of a healthcare bias where we all talk about doctors and nurses and training doctors and nurses, and yet the rest of the healthcare system has huge training needs. So I looked at how could we create a pipeline of caregivers with a role that gave people entry-level opportunities to grow their careers. And this was right before the pandemic. I pitched the first program in about 2018. So we started right then, and I was a chief nurse officer at the time. We started with a CNA program. And I'm actually really proud to say that we had the first hospital-based CNA training program in Washington State that was certified. Modeled it after what nursing homes had CNA programs and tech schools had CNA programs, but we never had a hospital-based CNA program. And so that was the first program I helped develop. We had a CRNA program that we had hospital-based in partnership with a university. We've had some other programs that were more academic in nature, but this was the first entry-level program. And once we started that approach, then the pandemic happened, and it all got worse. I doubled down on the opportunity to say, we're going to look at workforce development, not just with CNAs, but what are the other opportunities to grow entry-level folks into the organization and then build their own portfolios afterwards and give people a living wage.
What else are we talking about beyond nursing then? There's a nationwide CAT scan tech shortage right now. What is the pathway for radiology technicians, for lab technicians, I'm assuming that's where we're talking. Talk to me more about that.
Right now, we have programs that have developed over the last 5 years for respiratory therapy, for an internship with respiratory therapy, which is in coordination with our community college, a phlebotomy training program, which is an entry-level fully owned by the hospital for certified phlebotomists, med lab scientists, so med techs, which is also, that one is a tuition-based. So that one has had a tuition-based, and then we train med techs for the lab. We have a CNA program, a pharmacy tech program that also is in play. And then one of our programs we started that I'm actually really proud of is what we call the Providence Healthcare Academy that's in conjunction with our high schools. So we took the tech programs at the high schools, and we have sterile processing, pharmacy, really see another CNA program there. We actually have a culinary track for folks who want to do dietary, just different sorts of entry level work. The one that I think is the most powerful and has really made a difference is a sterile processing. That program, as sterile processing techs, are hard to find. They are essential to the running of an OR. And how we have structured it is they get high school credit for the work they're doing, and we pay them a wage as well. So they get high school credit and a minimum wage. And and then when they get out of high school, we hire them straight out, and we are 90% hiring students from this program into entry level roles. And I'm really proud to say we're in year 3 of it. Our 2-year retention, because the 2-year retention of our first class is 92%. Like,
Wow.
people are staying because they've been invested in. I also have one of our training folks who is in the surge tech program, who's now part-time going back to school, or not surge tech, the sterile processing tech, who's going back to school to become a surge tech. So to me, those are really critical opportunities to think differently about pipeline outside of formal academic training. Not everybody's going to go to college, and we know that.
And so these individuals are applying into a role within Providence. They get hired and then they get put into the program. So the hiring decision
Yes.
comes first. Is that correct?
Correct. And
Okay.
it's a joint hiring. They have to apply, and it's joint hiring between both Providence and the high school.
Okay. Thank you. How did you decide where to partner and where to fully own the program?
So I have a preference for partnerships because I don't believe we can do everything ourselves. And there's people who have good skills. The way I looked at partnerships was really building on existing relationships. So we have a great relationship with our community college. That was the perfect folks to approach around, can we do some internships? Can we partner differently? The school actually came to me because they heard about our willingness to engage in this work because of the CNA program and because of the tech programs we'd done with the community colleges. And so the school came to me with this big, bold idea and said, we'd like to put 25 students a year into your program. And so we have done that. So once you start, it's a flywheel. Once you start a little bit, those kinds of programs, word gets out, and other like-minded people who are interested in workforce development see you as a place and a willing partner. It's actually unfortunate that so many healthcare systems aren't willing to try something like this. I'm very fortunate because and I'll say, I think because of the CNA program, we showed success that when I ask for a little more dollars to invest in another opportunity, there's trust there that these are good opportunities to bring people in.
Have you done a strict ROI analysis on decrease in retention and what you're not paying for on per diem or ad hoc or staff that are coming in to fill those slots?
We did with the CNA program early on. We have also with these others. One of the biggest benefits that's a very clear ROI is we've cut the orientation time by 3/4.
Wow.
Because they've already been trained while they were doing it as an intern or doing it in the educational program. One of the other solutions, and part of any sort of a program like this, is getting staff buy-in. One of the things we did with the CNA program was how we gained staff buy-in who were worried about the time it would take to train these CNA students and the threat that was perceived by our union, frankly, of what are these folks doing in here and are they going to take jobs from our CNAs, was we had a huge need for patient attendants or sitters
Yeah.
because of the increase in violence. Nobody wants to do the sitter job. It's just a hard job. So we slotted our CNA students to half time of their training be the sitters. And that gained the what's in it for me for the staff because they didn't have to do the patient attendant role as often because the students were good doing it. And frankly, it's a great student role because you get to do patient care. You're one-on-one with a patient and you get to learn the CNA tasks. And then they also had half the time doing a more traditional CNA role. So sometimes you have to get creative of how you structure a program and you can't be too attached to here's how we're going to do it. Flexibility is most important.
You talked earlier about how proud you were of the Sterile Tech program. What other programs or partnerships are you most proud of?
I love the partnership with the high school. I just think it giving young people an opportunity to make a little bit of money. And most of these kids are kids who are from poorer parts of the community. Really, to me, is also part of the mission is how do we create living wage opportunities and folks who can see a future for themselves. The first academy graduation, I had somebody come up to me and say, this is the first person who's ever graduated from a program like this in our family. Like we didn't think that they'd have an opportunity like this. Those things feel great. Other one I'm really excited about that just started this year, and this is the whole flywheel part, is both in our phlebotomy program and our CNA program, we have an English as a second language track for training those folks we have a large immigrant population and really giving those folks an opportunity in coordination with our English as a second language program through our community college have put those together. And we have about 20 kids right now in those two programs. And that's a new pilot program that I'm really proud of.
With that high school that you're partnered with, that's one high school, not necessarily a school system. Is that correct?
It's actually through the school district who
Okay.
has a tech track, and then
Okay.
it's with the new tech program.
And the way you've described the students that are coming into that program, it sounds like that this is schools within the school district that we're not talking about an affluent suburban school that you've partnered with. This is an area where these individuals have an opportunity to be developed and they're likely not going someplace else either.
That's absolutely correct. These are students who are not on a college track, either because they can't afford college or they aren't geared towards a college academic track post high school.
What key factors can you point to that have made these programs successful? You've talked about the flywheel. Clearly it's successful because it's expanding, but what is that secret to success? And maybe it's different for each of the programs, or is there some common thread?
I'm a huge believer in the pay to learn programs. A little bit of pay is a huge incentive and it creates some loyalty and it creates a mindset of I'm not just a student floating through this, but like I'm getting paid. This is serious, legitimate work. So that I think was really important and has made a difference. One of the things I realized early on is I had to give some budget relief to the hosting departments. So if I'm paying the pharmacy aides, my pharmacy director was immediately concerned that he would be in trouble for not meeting his productivity targets. So I had to create a system that gave some relief from that, which was an easy barrier to get across. But it's an important one because you don't want to create a disincentive to accept students into the department.
And what is that? Did you modify their target or did you house the hours in a different cost center?
So because the number of students we have at any given time for the pharmacy program was fairly small, I did a simple calculation and said, okay, so it's this many hours. I won't fault you at all for being at this range. You can get to 99%, but if you're at 97, that's not the students who's causing that. It's a
Okay.
little bit of just because we have productivity systems that are very structured and booked and baked in. It was more of a kind of a line item that says, you get relief for this many hours of pay period. And it was so simple to do, and yet it made a lot of difference in that. It does also take a champion. And I do have, as this program has continued to grow, I have a paid position that's a workforce development program manager to do the connections with the school, to sit with different departments, to help explain, to welcome the students, to watch out for if they're in a situation that isn't good, where the department's either not being helpful or the student is not a right fit for the program. So somebody has to be nurturing the program along the way. This can't be somebody's other job and an extra thing because it will fall apart if it doesn't get nurtured.
So
And
this is one person that's solely devoted to overseeing basically all the programs.
correct.
Okay.
And being the liaison, not the technical overseer. I have a there's faculty and other folks who are
Sure.
involved, but somebody who oversees the program and is that broker for what's the next school district that wants to be a part of things, who's the next partner that's potentially out there, and also keeps the programs front of mind, tracks the ROIs, the budget. Here's what we're going to invest this next year. It's very much a business investment.
Are there any programs that didn't work? And if so, can you share lessons learned?
I haven't had any that totally failed, but I've had some that have limped along and really didn't fly the way I had hoped. One was we had a medical assistant apprenticeship, and it has struggled. And I think it has struggled in part because it didn't have a champion earlier on. And we've woven it into the bigger program. And I believe it's going to take lead now. It was a siloed off program that was done in the medical group without the oversight and like I said, the champion. It just struggled because it was well developed. The program was great, but the buy-in wasn't as strong. And I think here again, it's having somebody to have those crucial conversations. In the same way, we still try. We have had a surgical tech residency that has been a little bumpy. And we've got, once again, I think we have struggled with having the right trainer and the right person in the role to nurture it along. And as you know, ORs can be a tough spot, and they are not for the faint of heart. And so finding the right match and the right temperament of a surge tech program is a challenge in that space. It's not that they haven't worked, but we haven't landed the plane on that one yet.
Got it. What advice would you have for others about where to start if they want to develop a pipeline program in their healthcare setting?
Do the time to build a business case. You're going to have to convince people that this is worth it because there is an investment early on. I wholeheartedly believe in the ROI. The good thing that happens now, that's in place now, that wasn't in place when I started the program, is we have a nationwide workforce shortage. So the compelling why sits right in front of us. So that part is good, but you do have to think of it not as a humanitarian issue. This is a business, and it's a business case development. Start small, but not too small. Like, you can't do it with onesie twosies. It won't work. I would suggest pick one program and get a cohort that is 20 people, 10, 20, 30 people, and build the success off one program rather than having 6 programs all with 3 or 4 people in them. That will not help. Look at where your shortages are in your healthcare system and gear it towards them. If you're having radiology, tech issues, maybe that's the place. If it's OR, where are your largest workforce? Environmental services. There might be training opportunities there, whatever brings people in, but gear towards the shortages you have. And then I would firmly invest that you got to have somebody who nurtures it. It may only be half time as you're starting a new program, but somebody's got to have eyes on all the time. And that person, we decided to house them in HR. I've also seen programs that house them in their education departments. It can be either, but it is that partnership between administration, human resources, and education. That's the triad. You've got to get senior leadership buy-in, and however high up in whatever organization you're in, so that the bumpiness is expected. This isn't a quick fix. It's a fix that takes 2 or 3 years to start to really see the ROI. But I believe to my core, it's worth it.
Now, you're the chief executive over an entire region, which encompasses hospitals in a metropolitan area, and then you also have critical access hospitals.
Yes.
These programs that we've been talking about, are they unique to one individual hospital? Do you have people is it region-based? Do you have individuals that are being trained and actually working now in your critical access hospitals? How does that work?
So we started at the largest hospital at Sacred Heart, but now we have students in all of our hospitals, including our critical access hospitals. And the critical access hospitals, which happen to be about 60 miles away from the metropolitan area, have developed, using the template that we have as a region, have developed their own individual program, because you just can't scope it across that many miles. So they have a half-time trainer. They have 6 CNAs between the 2 critical access hospitals, and they're doing the same work. They are actually starting a program with their high school. One of the beauties of small hospitals and small towns is everybody knows each other. And so they're able to partner in very different ways with far less barriers than you are in a metropolitan area. So I've let them grow it organically of what makes sense for them. And they're doing it. One of the great things about small towns also is if you can give employment to people in these small communities, they love staying in their small community. And so it's also a great way to build a workforce in our very fragile rural health system.
Any closing thoughts as we wrap up this episode?
Investing in our healthcare's future cannot rest just in a traditional academic model. And I just challenge everyone to be creative and be bold and try something to bring in the workforce. We cannot recruit and hire ourselves out of the workforce challenge. We're going to have to grow our own.
Building your workforce pipeline as a nurse executive has been our episode topic. Susan Stacey, thank you again so much for your time today.
Thank you, Nick.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.